All right, so I have got a 26-year-old man who's presenting with swelling of the upper lip and tongue. The patient does have a medical history of angioedema. In fact, the patient says, I've had 6 episodes just like this before. He's had a complete workup. It is believed to be genetic, although not exactly clear what process is underlying all of these events. He's on no medications. He has been intubated once for angioedema. And that's one of those questions where we ask and we hope that the patient says, no, nothing like that. But he's like, no, I just got intubated like 6 months ago. This is a real thing for the patient. And he states that about an hour ago, he started to get some swelling and it rapidly progressed. He kind of knew where this was going. And so he immediately called 911 and came to the hospital. I'm just going to give you a quick exam before we kind of dive in. There's no real diagnostic dilemma here. We know what's going on based on the patient's history. His lungs are completely clear. And actually, aside from his face, his exam is completely normal. But his upper lip is pretty massive. It's about 3 to 4 times the size of his lower lip. So we know something is clearly going on here. His speech is pretty clear, too. And when he opens his mouth and I look in the back, all of that looks fine, too. It really does seem to be localized to the anterior tongue and that upper lip. Jan, when you see a patient like this, what are the first things going through your mind? And with that, are there certain medications that you're like, I have to administer these medications to this patient now?
You know I'm going to say yes to that question. But I think, the upper lip and that anterior presentation is reassuring. As you said, his voice sounds okay. Maybe this is going to contain itself to the anterior portion. But our job is not to think of what the easiest route is going to be. It's to think about what's the worst thing that can happen. So, of course, I'm thinking, well, maybe it looks okay now, but it could certainly progress. Maybe I have an opportunity here to get ahead of it and to really, think about what needs to be done next. Now, I think standard of care would dictate that you presume this is anaphylaxis, even though he has a history of hereditary or what sounds like a hereditary angioedema. It would still be standard of care to administer the anaphylaxis package, right? That would mean epinephrine and steroids and, diphenhydramine, all the things. And many of you might be listening to me thinking, well, that's ridiculous. This is hereditary. Those things aren't going to matter. But honestly, with an airway emergency like this, it is the kitchen sink approach. And I would throw those things in. It's not going to hurt in this person. It's not going to hurt, and it could help. What about you?
No, I 100% agree, because angioedema can be a presentation of anaphylaxis. There is a certain percentage of anaphylaxis that's going to present with angioedema. So why not try the epinephrine? I mean, for all the other stuff, we've talked about this in the past. It's not as important. It's all about that epi. If you give the epi and it reverses things, fantastic. That's a win for everybody. There's so little downside. So we did the same thing. The epi was the big thing. We went ahead and threw 0.5 milligrams of epi-IM at the patient. We did all of the other stuff as well. And we kind of knew in the back of our minds that it wasn't going to work, but we did it anyway. That's fine. It didn't actually work for this patient, but it started us thinking about other more specific medications, like should I give tranexamic acid? Should I give fresh frozen plasma? We've talked about some of these things in the past. And then there are the medications that are specifically for things like hereditary angioedema. So should I give something like icatibant? And Jen, of course, that presumes that I actually have the medication. But if I have it on hand, should I be calling for those things?
Yeah, I think these are, so TXA has been the darling of late. I mean, a lot of people have been talking about how TXA may be helpful. It's one of those complex, if you're wondering how TXA works in this pathway, remember that it's lysine, it's an amino acid derivative. It works in this very complicated way, but it has to do with binding to plasminogen, preventing gotoplasmin. It's one of these complicated with lots of arrows pathway. And in the end, it reduces bradykinin. And I think everybody knows that hereditary angioedema is bradykinin mediated. So ultimately, what TXA does, or what it is attempting to do, is reduce the amount of bradykinin. The problem with it, well, the upside is that it's cheap and we all have it. The problem with it is that there's not a lot of evidence to support that it works. We don't have any trials that say that this is really a great answer. But, on the other hand, again, it's cheap. Maybe it helps. So I think a lot of people have been trying it, and there's anecdotal evidence of it working. There's also anecdotal evidence of it not working. So, I think it's kind of up to you. Would you give it? I don't know that I would give it, honestly. I'm not sure.
I think there's so little downside that I would give it, but I wouldn't count on it working. And I think that's one of the things we have to kind of separate in our minds, right? Is I'm going to do it, but I don't expect it to work. So if I do it and the patient isn't getting better within, I don't know, 5-10 minutes, I'm not going to expect any benefit. It's one of those things where it's like, if somebody brings up, do you think we should give TXA? I'm like, sure, give TXA. But I'm not rushing for it. It's not the win. FFP is one of those that people often do talk about as like, oh, this is the drug that's the win. There's plenty of case reports out there of FFP improving these patients. But, we have addressed this before. It's been a while, but we talked to Gentry Wilkerson about this, and he goes, if you had a patient with angioedema that you gave FFP to and they got worse, would you write that up and publish it? And I'm like, yeah, Gentry, that's a pretty good point. I probably wouldn't publish it. And so there's clearly a bias in the reports that we see that are written up and we see in the literature. And his contention is that while FFP does contain enzymes that can break down bradykinin, it also contains bradykinin. So we might be stoking the fire by giving FFP. And it's also going to be delayed. Even if you really thought that it worked and you wanted it, it takes a while to get it. So we didn't give FFP, but we did give tranexamic acid. And I'll kind of cut to the chase, Jan. The epi didn't work. The tranexamic acid didn't work. And when I went back and was kind of reassessing the patient, I didn't think things looked that worse. But I just asked the patient, I'm like, how do you feel? Do you feel better? Do you feel worse? And he's like, I think the back of my throat is getting more swollen and I'm worried. And that to me was like, okay, listen, this guy's gone through this 6 times before. He's been intubated once. I got to trust that he knows what he's talking about. I think perhaps we are moving forward with our management here, which really means that we have to control the airway. And then it just brings in a whole different number of things that we think about here. So if you have a patient like this and you're thinking about controlling the airway, which honestly we should be thinking about immediately, so we prepare everything for it. But what are you kind of getting together, assembling your team as to what you're going to kind of bring to bear for that patient?
So there's a couple options here, and I really do want to make sure that the posterior airway is involved because I've seen too many times that it's really anterior and it's a lot of drama going on in the front. But honestly, when you get to the back of the airway, there's not that much going on. So I would like to take a look. There are 2 different ways that you can do it. One is by using one of these flexible flexible bronchoscopes. I want the ambuscope or the Verathon makes one too. There are different brands of these now that you can get. They're disposable. They're easy to use. You take a quick peek and see what's going down around the cord, see what's happening down there to see if this is really progressing. This is also a really good technique to use in patients with burns. You have some soot around the mouth. You're not sure if there's actually any airway involvement, but take that quick peek. You can also do it with really good local anesthesia. You can nebulize lidocaine. You can use, any local anesthetic option and take a peek as well. You can even do that with the laryngoscope. The problem with the laryngoscope is that you don't want to muck around too much. These people are like very prone to swell. That's the whole problem here. You kick off that bradykinin pathway by, kind of nicking something or pushing a little too hard, and now you've created the edematous problem. So to do all of this with the finest touch possible and to also be prepared to intubate, because if you do find that it's swollen, then you just want to put the tube in because you're already there.
I think those are really good tips because if you want to take a look and you're like, I'm not really sure that the posterior airway is all of that involved here, just be ready to put that tube in case you see something. I think that is a great tip. So don't just go in saying, I'm just going to take a peek. Go in saying, I'm going to take a peek, but I'm probably going to put a tube in. And that's kind of how we set up. And I went back and asked the patient to open their mouth and let me look in the back and let me see what things are like. And it actually did look just grossly it looked different to me. And I was worried between the patient saying, I feel more swollen in the back, and then me looking and being like, that airway doesn't look as clear. That posterior pharynx doesn't look as clear as it did when I first looked at this patient. I said, you know what? We're going to go ahead and intubate this patient. We're going to get everything ready. And fortunately, I think those disposable scopes have become so much more common in emergency departments, and we have one. So I had all of those things ready to go. I had the disposable scope that we can use to look. We didn't think we had enough time to do a full topicalization with lidocaine, mainly because when I look back, I'm like, I don't want to wait 10 or 15 minutes to do that full prep. But fortunately, we have more ketamine than we know what to do with. So we had something that we could use to facilitate that process without having to do a full topicalization. So Jan, if I told you all of this and you're like, okay, I'm like, Jan, you have to intubate this person. Right. What's your choice? How are you going to approach? What's your primary approach to intubating that patient?
So my primary approach is typically a nasal approach, knowing that I may be encountering more edema when I go in through the oropharynx. So I usually go a nasal approach. I'll usually dilate with some nasal trumpets first to kind of get some room going. All of this takes some cooperation and preparation. Ketamine is a great adjuvant, in terms of adjunct. Ketamine is a great adjunct to get this done, and to go through the nose and to preload the tube on the long scope so that once I get through the nose, down around the corner, taking a peek, I'm pretty much ready to feed the tube. And that comes with also a preparation to the post-intubation sedation, because this is something that, they can wake up and pull this tube out very easily. If they were getting ketamine while the intubation was happening, ketamine wears off, they wake up. I mean, obviously post-sedation is always a key element to all of this. Even some soft restraints can be helpful so that nobody reflexively reaches out and pulls out a tube. So yeah, I usually do a nasal approach. That's kind of what I'm most comfortable with. And that sounds weird because we don't do a lot of nasal approaches, but that's the one that I usually use in this scenario.
Yeah, I don't like to overthink it too much. And the nasal approach is great if you're comfortable with it. A lot of the advice around here, Jan, is really to do what you are comfortable with in order to control this airway. And I like doing fiber optics through the mouth. So that's kind of what my go-to is. That's what I usually teach. And I usually teach the residents and the other faculty that I work with that doing a ketamine facilitated approach is really helpful when you have a little bit less time. You can't do that full topicalization. And so if you were to ask me outside of this clinical scenario, I would tell you I would do ketamine. I would do a scope through the mouth. Obviously, I'm going to have a double setup, so somebody ready to cut the neck if necessary. I also like using like a video laryngoscope and doing ketamine, but then just using a standard geometry video laryngoscope blade in order to take a look. So I have all of that stuff ready to go. Here's the thing, Jan, that's what I teach. That's what I say over and over again. When I was actually faced with this, that's not what I did. In fact, I just went with a full RSI for this patient. I did ketamine, I did rocuronium, I did a standard geometry blade on a video laryngoscope, and I went back and there was quite a bit of swelling in the posterior pharynx, but I was able to get a tube in. In fact, it really was a pretty smooth intubation. But afterwards, I was kind of looking at it like, what did I just do? Like, why did I do that when I had all of these other options in mind? I think I didn't fully consider the dangers of RSI. And I think that's what we kind of have to talk about, is because we do RSI every day so many times. What's the danger in doing his RSI in a patient like this?
Well, to your point, doing what you're most comfortable with is often the advice that we give. Use the method that you have done over and over again that you're the most confident with. So I don't think that you're wrong to have gone that way, and I can see the rationale of it. The danger, though, as mentioned, is just that there's a lot more theoretically direct trauma, as you're kind of moving the laryngoscope around, trying to reposition, see where you are, versus going in with the fiber optics, taking a peek with this nice little delicate, little tube that's like less than a straw almost, and looking around without, hitting things. Because as you hit things in that airway, they are going to swell. So as you go in with a laryngoscope and you're kind of moving around, trying to get in the vallecula, you're this, that, the other, you're bringing on more edema, honestly. That would be my fear of it. But if you were to with the video, if you're able to get a quick peek, a good look, and get your tube down, you're going to be fine. It's just a matter of whether you can execute it that way or not.
The other thing I worry about is giving the paralytic, because I've got this awake, spontaneously breathing patient. They're maintaining their saturations. I give them the paralytic. I stop them breathing. That's its own issue. Right now, I've got an apneic period. I've got to put something in. I might reduce the amount of time that I have to do that. But then there's also the issue of this patient's muscular tone might be keeping that airway open. It might be maintaining anatomy. And so by paralyzing them, I take that away. And now I might have a real collapse. So whereas I look in the back of their throat, I'm like, oh yeah, there's some swelling back there. Now I take away their muscular tone. That airway might completely elude me when I go to intubate. So the paralytic to me was really the thing that I feel like I should have not used in this patient, kept them awake and breathing, and done this with just ketamine, or if I had the pre-thought, do a full topicalization. And again, I was very lucky that this worked fine, that the tube went in, there was no desaturations, everything worked out for the best. But it kind of brings us to this issue, not of just how do we approach this airway and how do we take care of angioedema, but the bad process, good outcome. And Scott Weingart has talked about this in the past, where we might not do the best thing, but we get lucky and everything ends up being fine. And so it's easy for us to take away from that, you know what, I'm just good at intubating. It doesn't matter what the situation is. I can just RSI everybody. Don't overthink it. Just do that. And it's that idea of just because we have a good outcome doesn't mean that the process was the one we should have gone with.
I think that's true. I just want people, who are in the world, like if you don't have one of these flexible scopes and your RSI is what you
can still
have,
control the airway.
It is fine. You can still control the airway. So I don't want to, people to take away that RSI is bad in this scenario or wrong. It's not. And if that's what you're most comfortable doing, I would still go with that. I think that there is still a bit more upside to you doing what you're most comfortable and confident in than there is to avoiding it for a lot of theoretical reasons. So, it is still a good way to go. And I'm glad you had the good outcome. It's always good to reflect and talk about what could have gone wrong. But in the end, there's a reason you got that airway because you were most comfortable with it. And so it was a good choice.
I think it's the matter of if you have options in front of you, really think carefully about what the best option is and go with that. And that's kind of what really came back to me. And I've talked about this case with a number of colleagues. I've talked about it with the residents over and over again, because I think it is easy for us to focus on the outcome without really thinking about the process and how to do it better. And I think that reflecting on the case can be really valuable, and trying to figure out why we did the thing that we did, even though maybe we know it wasn't the best approach in the skilled hands that we had, right? It's about the skill set that you have. If you don't have the skill set, you don't have the tool, then you do what you have to do. But in this case, especially where I work, I had everything available to me. This probably wasn't the best way to do it. So I think it's important for us, not just, again, in this case, in this airway, but to think about, was this really the best approach, or could I have improved? Could I do it better for next time? And what skills do I need to hone for myself in order to be more comfortable embracing one of those approaches the next time, so that almost becomes the fallback?
Well, it takes some humility to step back and do that and realize that, had there been a bad outcome, I probably started with the wrong logic. And so, I do think that humility and that reflection is really important. And we should do that on all kinds of things. This is an intubation case, but, think about a trauma case. You make a decision to send someone to CT and something goes bad there. And then you reflect and say, I probably shouldn't have sent them in that moment. Rethinking the order of events in those dynamic cases can also, maybe highlight some areas where your decision making may have been pushed by a reason that was external to the actual patient well-being. So yeah, I agree. It's good. It's a good practice.
100%. I think about this a lot in trauma activations with, did I activate my massive transfusion protocol? Did I activate it at the right time? Should I have activated it earlier? Because we record a lot of our trauma resuscitations and we go back through those. And a lot of times, when you think about it afterwards, you're like, oh yeah, I activated a massive transfusion. It was no big deal. And then you go back and watch and you're like, oh, I took a long time to activate that massive transfusion. And again, it's great if the patient does well, but we have to really look at the process too, so that we can refine that process for the next time and the next time and the next time. So I agree with you. I think it's really important for us to think about these cases, to talk them out. Fortunately, I have fantastic colleagues at work that I've been able to talk this out with and say, what do we do in order to help people, to get them to what could be the more skilled decision, the better decision in these kind of cases. So this is my case, and I'm really happy. The patient did totally fine, and is also prompted a lot of conversations about some of those things like icatibant. We only talked about that a little bit in the case, but there probably was a role for that in this patient. But Jan, we don't always stock that. I mean, it's definitely not stocked in the emergency department, but most of our hospitals don't even stock that medication. They're often centrally stocked. They have to come from somewhere else. But if you have a group of these patients that undergo these angioedema events, they have hereditary angioedema, you might just want to keep it on hand, knowing that it's a good chance I get one of these patients at my doorstep, and it's great to have that medication ready to go. So these are kind of the things that we've talked through. I don't think icatibant should be used for all angioedema, but the patient who's had 6 or 7 episodes, there's a family history, maybe that person should get icatibant.
There's also ecallantide, which is Berinert, which is also approved for hereditary angioedema. So there's that other drug. This is where your ED pharmacists play a huge role in helping you figure out which one. And often these are expensive drugs, so you have to go through an approval process or whatnot to get it. But, still, I agree with you. If they're indicated, they're probably a better option than the TXA or the FFP.
Yeah, in this case, the patient actually did get icatibant about 12 to 16 hours later. It took a little bit of time to get the drug. And after getting the icatibant, the patient did get extubated fairly rapidly. Now, I'm not saying cause and effect here, Jan. I can't draw cause and effect from this, but there was a lot of notations from our allergy and immunology team that this patient should probably get icatibant in the future because they seem to be a responder. We know that not all patients will, but this patient did respond. And so that was kind of put down in their chart. And the patient was kind of given this warning of, listen, next time you come in, just tell them this drug works for me. That might help to speed the process up and end up with you not getting an intubation. But the patient did fine, went home, and have not seen them again for angioedema. Cross my fingers.
Yeah, I'll cross my fingers for you too.
All right, Jan. Well, that's our case, and lots of different things to think about in there. I think it's really good to go through these processes and think about what your process is going to be when this moment arises and you have to take care of a patient like that. But of course, we have a lot of other stuff to get into this week. We have a great piece on orbital compartment syndrome with Scott Weingart. I just wanted to see what else we have this week. Oh, the Rogan one. We've got a great piece this week on orbital compartment syndrome and a new approach to taking care of that particular issue. And we've got another piece on ROGAM, which, Jen, ROGAM is such immune globulin. And we've also got a piece on RH immune globulin use, something that I don't know how many times I have written for that drug or thought about that drug, but a little bit of a change in how we should be thinking about it in the future.
Absolutely. It's a pretty big change, actually. And we do use that drug a lot. So if you haven't heard this update, this is one for you.
All right, Jan. Well, let's get into the week. Can't wait to see you on the other side.